I'm Quyên, I'm the coordinator of SUN CSN in Vietnam, and today I'm going to give you an overview of the gender-transformative nurturing care for women and children in Vietnam. And next, please, let's go. Yeah, briefly information about SUN CSN in Vietnam. We established 4 years ago, starting with 7 members, and then we doubled the member organizations into 14 at the moment. And we are operating in 40 out of 63 provinces in Vietnam. And we are providing technical assistance for National Assembly in Vietnam and the government of Vietnam. And also we conduct the intervention for direct beneficiary at the local levels also. Next, please. So the problem, I want to give you an overview of Vietnam. Like in Vietnam, we have a saying to the women that whenever a bad thing happens to your child, it is your responsibility. So basically, that is the saying that a lot of women in Vietnam we have to hear every day, whether it is about stunting, about not gaining weight, about diarrhea, about not getting to sleep. I mean, almost everything. The responsibility goes to the women. So you can see that this is kind of social norms that emphasize the care and unpaid domestic work as a women's responsibility. And in that context, it is very easy to understand that women in Vietnam, we are physically tired, when we have to stay up late, we have to take care of a child, the full time, and mentally tired. That is one of the reasons why a lot of postpartum depression appear at the moment in Vietnam. And so when it comes to work, when it comes to career development, women in Vietnam, we also face a lot of disadvantages, that we have fewer opportunity because we have to take the maternity leave, and usually a lot of women, they have to quit their job because they cannot balance between the childcare work and the career. And then they also have the restricted mobility because they have to stick with their child. So, and to make the problems even worse, that we are in Vietnam, we see that we are having a kind of lack of access to evidence-based information and support in childcare. It means that the women, they are alone, and they are struggling with finding the correct, the prestigious information about how to properly raise their child, from breastfeeding to complementary feeding, teaching and everything. So that is basically the problems in Vietnam. You can see that it is a lot of problems there. And I believe that this problem is a little bit, I think that this happened a lot in other countries, and I would love to hear your experience in your country and how things go. So given that the problem, what is our solution? So our solution today, I'm presenting about the nurturing care for children, caregivers, and families in Vietnam. We are, realizing this nurturing care by 3 methods. The first one, we ensure that caregivers, they have access to information and support to increase their knowledge and confidence in, childcare and feeding. Second, we engage family members in childcare to foster, sharing and understanding among families to avoid conflicts in childcare. So sometimes in some cases, when mothers, they have the knowledge and they want to do this way, for example, but their, let's say their mothers or their husband, they do not agree. So there's the conflict there. So we want the whole family into the childcare. So we avoid the conflicts. And finally, we take care of the caregivers' mental and physical health also. So we believe that it is not only about childcare, but also about the taking care for the caregivers also. So next, please. So today I'm going to briefly introduce you the 3 models in Vietnam that we are implementing in that nurturing care ecosystem in Vietnam. Actually, we have a lot more models in Vietnam because we are 14 organizations. So I just, picked up some kind of models here because, given the time constraint. So the 3 models include, the first one is Centers of Excellence for Breastfeeding. We usually call that COE. This is a kind of designation conferred upon the hospitals to signify that they are breastfeeding friendly. And we follow the EENC of WHO. EENC stands for essential early newborn care. standards of WHO for this COE. And the second model is Little Sun nutritional clinics that we provide nutritional counseling during the pregnancy and after the delivery. We also set up and operate these clinics in the collaboration with the hospitals. And finally, we have the Mumby application, Mumby mobile apps, which is an AI-powered mobile app that we have a kind of AI bot to accompany with caregivers for the whole process from pregnancy to delivery and to, raising up the child later. So you see that this is kind of, extensive and, comprehensive intervention from the pregnancy to the delivery and after that. So, and later on, I'm going to give you how we, are integrating these interventions together. So next, Nazwa. Yes, first we go to the Centers of Excellence for Breastfeeding. So as I mentioned, we follow the early essential newborn care standards of the WHO. Some of the, criteria are, we promote skin-to-skin contact for newborns. We ensure that mothers can successfully initiate early breastfeeding within 1 hour of giving birth. And we enable mothers to, exclusively breastfeed, regardless of whether they deliver, vaginally or via C-section. So this is some example of the EENC, the Early Essential Early Newborn Care of WHO. Actually, we have a really comprehensive checklist with this to work with the hospital to promote them, from training, from peer-to-peer training, and then we verify the practice of the hospital via, supervising trip and via the mobile, via phone survey to mother who, experience the service of the hospitals. Next, please. And in the COE, in the Centers of Excellence for Breastfeeding,
I'm so sorry, Kian. I forgot to do something that I was supposed to do very early up front. I'm really sorry for interrupting. It's just that I was supposed to say very early on that this whole talk is being translated in both French and Spanish. And please press the global icon for your translation in French and Spanish. Very, very sorry for that. And also, there will be a French presentation later. For those of us who are exclusively English speakers, please press the global icon then too. Really, really sorry, Kian. Please keep going.
Yeah, it's okay. It's okay. Okay, so keep going on with my presentation. In the COE, we also promote the family-friendly birthing room. What is family-friendly birthing rooms? We ensure that friendly and respectful maternity care. For example, usually in Vietnam, when they enter the birthing room, they usually, they all usually are naked there and they have to wait for a really long time in a quite cold room. So we encourage the practice of, treating mother with dignity with that. And we also encourage the birth companions throughout the labor and childbirth. For example, you can see in the picture that the father is in the birthing room. That he will, he witnessed all the process of giving baby. So he will know, how difficult and, of course, beautiful the process is. And I think that gives a very, big motivation, big encouragement for the mothers who is giving birth. And we also allow, mobility and an upright position during labor. For example, like the mothers, she can choose the position that she feels comfortable, for example. So this is some kind of example for you to understand, to have an idea of what is family-friendly birthing rooms. So next. Okay, next we go to the Little Sun nutritional clinics. So nutritional clinics here we set up in the hospitals that we work with the hospital manager. And then we develop a kind of set, a checklist, and also the materials, communication materials for the hospital, for the staff. They can use that to provide a counseling session for the clients. And during the Little Suns, actually the Little Sun, we will have 15 contacts. This is a standardized counseling service. The mothers will have 15 contacts over 27 months from the pregnancy, from the 3rd trimester pregnancy. The final 3 months of the pregnancy. they will receive the 3 meetings, I mean 3 counseling sessions about how to, latching baby, how to have the, exclusive breastfeeding, how to take care of the nipples and everything. I mean, to prepare for her for the giving birth and for the taking care of the pregnancy. And then with the childbirth, we'll have one more contact. In this contact, we will talk about the initial early breastfeeding within 1 hour of giving birth. And then for the next 6 months, I mean, when the baby under 6 months, we will have 4 contacts. Okay. Taras, I see that Calixta raised his hand. Should I stop or should we wait?
Do you mind if we wait until the Q&A, Calixta?
Yeah.
I'll keep a note that you have a question, and we can, if it's a very urgent one to do with Zoom, then please text on the meeting chat, and maybe that would be helpful. But otherwise, let's wait until Q&A for any immediate questions on the
stay tuned.
presentations.
Okay. So for the, as you already know, that WHO, they recommend that that mothers should exclusively breastfeed their child when they are under 6 months old, and then continue breastfeeding with the appropriate complementary feeding up to 24 months old or beyond. So you can see that each column, we illustrate the context and the contents of that context is about the exclusively breastfeeding. I mean, EBF stands for exclusive breastfeeding. And the CF promotion is that complementary feeding. So we will introduce the complementary feeding when the baby is 6 months. And then after that, we will follow up with the complementary feeding, monitoring for the mothers. So you can see that among those 15 contacts, we have 9 in-person contacts, meaning that the clients, the women and her family, they will come to the hospital to receive in-person counseling session, and 6 other contacts are online counseling from Mumbai, which I'm going to introduce very shortly right after this. Next, please. So the Mumbai apps also the final models that this is a kind of, I mean, SUN CSA, we provided technical assistance for technical advice for and tech startup. This is a kind of business startup, and this is the app that it provides maternity assistance. It is co-built and recommended by obstetrician, and you see that they will have a kind of AI bot named Doti, and the mother they will input the, let's say, which month they are in their pregnancy, and during the time that AI bot, it will follow the mother and it will provide mother with the information needed for each development stage of their child from pregnancy and after the delivery. Next, please. And beside the receiving the information from Doti, I mean from the AI, the clients, I mean the app user also can book the counseling with the real doctor. I mean, you can see that there is a list of doctor there. You can book that. The price is also display very clear, and they also have the review mechanism. I mean, it's like a service provider there with a very affordable price. And next, please. So you see, I'm going to talk a little bit. I see that I only have 1 minute left to go. So you see that, so I've just mentioned about 3 models. The first one is Center of Excellence for Breastfeeding. The second one is about the nutritional clinics named LeaderSun. And the final is Mumbai apps. So you can see that we can combine these and introduce them to mothers during the pregnancy after the delivery. So we can maintain the Mumbai user after the childbirth at the Center of Excellence for Breastfeeding. For example, after the delivery, the doctor, they can recommend the Mumbai app for, customize accompanying with the mothers. After that, we also connect with, via Mumbai app, they can also connect with moms of babies born in the same month as yours. And one more thing, another very interesting function of MOMBI is that they are expanding to, maternity and postpartum depression, to take care of the caregivers. And they also have the separate section for new dads, meaning in that section, the dads, they will receive some kind of information about what they can do for their child, what they can support, and how to do them properly. So next, please. And during the counseling session of Little Sun nutritional clinics, as you can see in the picture, the doctors or the nutritionists can also, introduce the MOMBI, because you see that the Little Sun is kind of in-person counseling, and the MOMBI is a kind of, extended counseling for that. So the mother, they will have, 24/7 counseling, 24/7 support. And, it is like a very well matched together. Actually, COE, Little Sun, and MOMBI, we developed those models in different time, in a different, period. And now we are trying to, combine and integrate those models into, a more extensive and comprehensive models in Vietnam. So next, please. Yeah, just next. I will skip some slides just to, okay, this one. So this is my final slide. I'm going to talk about like what to take away. I mean, this is the big picture that we applying the gender transformative lens to nutrition. So for us, from our experience, it is very important to keep in mind 3 R's. I mean, recognize, reduce, and redistribute. About recognize, we need to recognize that care work is valued and understood as vital societal well-being. We need to reduce the amount of care work for women and redistribute the care work to other, including male partners, other family members, employers, and the states, so that women are no longer, bearing a, disproportionate care responsibility. And to realizing this goal, we need effective communication, advocacy, and direct support. So basically, those are the 3 models that we are implementing in Vietnam. So over to you, Tahrat. You are on mute.
Thank you so much for sticking to the time here, and despite having to interrupt you a couple of times. I'd like to go ahead and move on swiftly to our Sri Lanka speaker, and then we can have a quick Q&A. I wanted to introduce Visakha Tilakaratne. She is the representative of the SUN's People's Forum at the Civil Society Alliance of Sri Lanka. She'll be discussing their interventions for promoting breastfeeding and the awareness and training programs on child feeding practices that they implemented as well. She's been a development practitioner and activist for over 30 years. She's a chemist and food technologist by profession, but she has years of experience working in the government and private sectors in this context, as well as others at NGOs and at the UN. She's worked in a number of UN agencies. She's been an inside staffer of WHO and WFP and a consultant of the World Bank, ILO, and USAID. She also has a development consulting firm and sits on a number of organizational and trust boards. She is currently a consultant for the FAO Food and Nutrition Resilience Building Project. She's also the project director for the SUN PF in Sri Lanka. She currently specializes in food and nutrition security programs and projects with cross-cutting themes of gender, HIV, and AIDS. So I'll give it away to you, Visakha, if that's all right.
Thank you, Tahrat. Can you hear me?
I can, yes. I think you're clear.
Thank you very much for a very generous introduction. And I think, from Vietnam, if we connect up the presentations, the background given was excellent. And therefore, I have my work reduced to provide the background. Very, very briefly, before we get into the topic, Sri Lanka has a history of 123 years of primary health care. The first clinic for moms and children started in the year 1900. So while that's a very illustrious history, we also, through the years have had lots of aspects to improve. And our system is a national, provincial primary health care system. So the national ministry and its directorates actually manage the policy and the technical aspects of maternal and child care. And then it is divided or segregated into the provincial system, which has a provincial director of health, and under that the sub-regional district directors of health. Beneath that we have blocks or divisional directors of health, and then the public health midwife system. Now, our public health midwife system is very well knitted because we have a midwife for every 3,000 productive age, 15 to 49-year age families. And we also have public health inspectors for the program. So I just wanted to set the setting. And actually, it is a very rigorously supervised and monitored system. 99% of our children are born in hospital. And so from antenatal to postpartum to postnatal, there is a very well organized continuum of care. However, a bit of a gaping hole is obviously gender transformation, and the gender dynamics that go with it. So we have titled our experience. So we have actually got a snapshot of 2 programs which were driven by Scaling Up Nutrition, the People's Forum. So the SUN CSN in Sri Lanka, I'm not going to talk too much about it. It is 10 years or a decade old next year. And it is registered, as a non-profit private sector entity. And we are very, very happy that, before I just took over as project director, but the previous project director and the chairman of the SUN PF have done an excellent job of garnering the support of 300 civil society. Actually, it's a little more than 300 civil society organizations in all 25 districts of the country. And it's very interesting that there's a youth network. There has been a youth program to capacitate youth in nutrition, and 1/3 are women CSOs. And we also have the SUN Business Network. And we hope that in the future we will also have an academic network. So we are also, we had a government focal point, but at the moment it's being replaced. Next slide, please. Yes. So I would like to, start with a definition of gender transformation and what is actually transformative. So transformation is actually the process too, as is obvious, and it is a gender equitable process to result in gender equality. So I think, it is a very fundamental and very in-depth subject, so that, inequalities in power structures between the genders, is something that really needs to be challenged. The gender norms and, harmful and destructive norms particularly need to be challenged. And as wonderful as our systems are, we have this, inequality in every layer, from the officials to right to the beneficiaries, that imbalance is there. So though a lot of the health staff, as well as other multi-sector actors, talk about gender transformation, transformative programming with the actual objective of transformation in both nutrition and gender takes a lot of doing. So again, there are many donor-driven, programs and also policies driven by the multilateral institutions, particularly the World Bank and the ADB, has a lot of emphasis on sensitizing on gender and then putting that into application. But it's a long haul through the layers. So let me get down to 2 very simple initiatives that were driven by SUN. Just before we get into that, we have looked at this whole landscape of transformation as 3 big boxes, or the 3 results. And as we all know, and as I explained, gender transformation is not merely women targeted. It is a lot more. It is a transforming of all genders. And the 3 boxes look at, personal transformation of the primary target audience, then the resultant, engaging of men and boys, particularly through the lens of child feeding, we look at these two genders, so engaging men and boys, women's empowerment and decision making, as a way forward, and the process boxes, as it were, how do you work really with the gatekeepers of social norms? How do you actually analyze the root causes of inequalities? How do you actually, look at challenges and unplanned consequences? Is there a movement building? And how do you measure success? Again, these are all easier said than done. And I must say that through these two little projects, we have, kind of dipped our toes in the water, but we need to go a long way. But we have actually, looked at the first cracks of getting into this. Next slide. Yeah. So our springboard for transformation, the SUN People's Forum or the SUN Civil Society Alliance, the vision, mission, and objectives are explicit. In the third objective, the multi-stakeholder platform and CSOs are engaged in enabling nutrition, and it also highlights gender and all other topics that are mentioned. And we have also tried to drive with the government of Sri Lanka the multi-sector approach. Again, that includes a lot of gender sensitization. Again, we are right at the beginning of the multi-sector approach, having supported the government in the national multi-sector plan as well as the 8 districts multi-sector plans. Then, as I mentioned earlier, the SUN Alliance having a number of thematic groups, including women's empowerment groups, and also on our council, we have some of the largest NGOs and INGOs who definitely have empowerment on their agenda. And I would say the third layer is the capacity building of government officers and CSOs to prepare for transformative action. And that has been a driving force of SUN. So as I said, we have taken 2 very similar programs as examples of transformation. So one is a nutrition related, CAP among pregnant and nursing mothers in 6 districts. And we have also looked at the effectiveness of a mobile-based nutrition intervention. Now, this is not a kind of an application, but it is a messaging system through this. So very interestingly, in both rounds of these programs, a pre-assessment of what we say PNL, pregnant and lactating mothers, on the knowledge, attitudes, and practices, or rather behaviors, in selected divisions of the 6 districts has been completed. So that actually serves as 2 inroads. One is the mode or the medium that people would prefer to get the messages. The other is how internalized are the content or the messages that should be delivered. So the intervention has included multimodal forms, mobile phones, social media, and recorded programs on radio channels, and again, covering a broad spectrum of topics. And now the audience here might wonder, Sri Lanka having such a robust primary healthcare system, why do we have to, again, concentrate on these topics? Well, the answer is governments and systems are very good on messaging, but whether there is behavior change and whether the formative research again is measured, now that is questionable. So SUN really wanted to add on to kind of reinforce the messaging, and particularly on the family support to mothers. And a new element that was brought in was cash management, because lots of issues are not merely poverty or low income, but it is knowing how to manage your household budget. And this holds true even for some of us who are not quite good at managing family finances. And also another is violence at home. Now, I'm sure lots of countries have the same issue, but we in Sri Lanka, we are not ashamed to say that the gender balance has not been redressed, and there is quite a high level of domestic violence at home. And we also, after these interventions, have completed a post-assessment and this is segregated into a number of areas, such as the intention to change and the actual change. The next slide, please. Yes. So these, illustrate some of the pictorial communication that has, gone through the multimodal, messaging approaches. So here you see that father has taken also center stage, and out of the 3 gender roles of productive, reproductive, and social, the productive role emphasizes the father's, duties and support to the family. Now, again, these are not easy results to come by. So, as I said, needed reinforcement through these messages. It actually shows the support to the mother, the love and care. The next slide, please. Yes. Then very, very important of the father taking a share. As you can see on the first picture, on the left hand facing you, the father carrying out household chores, and the son actually also engaging. Some of these are again not usual pictures. So then the second on the left shows the engagement of father at mealtime and how both children, older children respond to father. And of course, again, the unity of the family, where the gender dynamics, need to be equal. I mean, though it doesn't give that explanation, but the gender dynamics at home are, I think, quite clearly shown. Next slide, please. Yes. Now, these messages, I mean, this is in one of the local languages, Sinhalese. And the first one, the first picture, talks about the goodness of breast milk. And the second speaks about the growing child and complementary feeding. And of course, it again looks at an underlined message about, in the second picture here, father's love and protection and the father's role actually in complete nutrition. So it also talks about the obtaining of food and processing or cooking, and also the feeding aspects. Next slide. Yes. So now this side of this leaflet that is shown, the first topic on top is about father's love and protection for both mother and baby.
Sorry
And
to
again,
interrupt,
it
Jessica.
looks-
I'm sorry. We're just getting, I think we need to close relatively soon, like within the next couple of minutes, just so we
Okay.
can leave a bit of time for Q&A. Sorry about that.
Okay, right. Okay, and this also shows the balanced meal and the importance of dietary diversity and father's role in dietary diversity. Over to the next one. Yes. So a similar program, I will not go into the details of this, has also been, built up based on this. And it includes actual hands-on awareness sessions on gender equality and father and family support. Again, it has the same kind of messages. So it's a concentration and going into a wider area. The next slide. The next slide, yes. Okay. So the programs, as I showed, the 2 programs, these are the numbers that were served. Next slide. Yes. I think it's very important when we talk about this intervention to show the evidence. Whether we use an app or whether we use interpersonal or whether we use multimodes, it's very important. So the post-assessment actually showed that 21.8% of those targeted said that there were many changes and very good improvement of the support received from husbands and family members. And of course, a lesser 45.3%, which is the largest percentage, said that there were some changes and improvement. So this was actually measured and statistically arrived at. Next slide. So the transformational aspects that we showed earlier, and we are just showing from the earlier boxes that were shown where changes have taken place. women are taking decisions to increase their dietary diversity of their children as they have understood the importance. I mean, the message has been driven more than the education system that is there in place in the primary healthcare. Then husbands are more supportive. That is the engaging of men and boys are supportive of sharing housework and enhancing the diets of mothers. Then dietary diversity is the ultimate, outcome. It has increased. It was already good, but it has increased. And men and women are more conscious of household cash planning, which is really the ultimate, that you have money and that you have the resources to build power. The next. Yes. So we have shown the changes, but we have actually not been able to start on movement building through this. Much larger numbers and more in-depth evidence is necessary, but personal transformation has been seen on the part of women, engaging men and boys. Then what you feed your children and how you manage your money, empowerment and decision making. We have made inroads into gatekeepers of social norms and looked a little bit at the root causes through the pre-assessment and also measured success. Next slide. Right. Okay. So I think I would like to thank Nasgol and the team for inviting us to deliver this, and I would also like to thank Roshan Dalabandara, who is the former chair of SUN PF, for helping with the presentation, and Subun, our program officer, for sharing some facts. Thank you.
Great, thank you so much, Visaka. We are going to go straight to Q&A now. I had a couple of questions. I'm going to just put them together and get the two of you to respond in groups of questions. So the question I have I'm going to use my prerogative as a chair to get to ask a couple of my own questions. So I have a question for Vietnam in terms of, this applies to Sri Lanka too, but we've got a bunch of questions for Sri Lanka, so I don't want to take up too much time there. So with Vietnam, I'm curious to know, in terms of, you described what the program was, you described what the program goals were, but I think one of the things that would be good to know is, how did you measure success? How did you assess that, oh, this program is actually working? It's a great model, and obviously common sense suggests that all of this sounds great, and it is a great program, but how do you actually evaluate that this program works? Well, I mean, in terms of assessing through evaluation, and being able to show that, look, this kind of program in this kind of context is actually an effective one. You also got a question from Dr. Behnush Aranjani, and he asked, have you tested the same approaches with the Thai ethnic minority as well? Those are the two questions we've got for Vietnam at the moment. And for Sri Lanka, we have a question from Anna Mbabazi, and she asked, in the context of Uganda, where there are quite a lot of especially vulnerable mothers who couldn't possibly afford smartphones, for example, could something like the Mombi app actually apply, given that this is a population, I understand this to mean that given that this is a population of such great vulnerability, that they don't even have access to smartphones. So would an app like this make sense in a community such as that? Also, you also have a question from John Otieno, and this is also about the Mombi app. He liked the integrated interface, but most of all, he wants to know, what is the proportion of uptake and utilization? So kind of getting back to evaluation of success, how did you measure sort of uptake in terms of urban-rural divide, in terms of age bracket using the platform? Who is this community? The way I understand this question is, what communities have this been the most effective for? I'm somewhat editing, but that was basically the question. So I'll let Kien Lu respond first.
Yes. So Nasco, could you please open the slide number 5 for me, please? Because in the slide I already show some kind of numbers, but because due to the time constraint, I did not mention that. So I think that is a very important question of you, Tahrat, about how we measure the success of the models. So we have really detailed numbers. Full screen, please. So for example, for the COE, for the Centers of Excellence for Breastfeeding, so far we started this model since just like more than 2 years only. But even only after 2 years, we have 86 hospitals register to, I mean, they register that they want to have this kind of, certification. And of course, they have to, be screened and be, trained and then verified by us, I mean, by Ministry of Health and by Alive and Thrive, because we work with the Ministry of Health in Vietnam to, to monitor the whole process and to, verify. We only verify the hospital with a COE certification once they are, qualified. So far we have like 1/3 of those registered hospitals certified. And the reason behind that, why they want to register for this, because this, we also advocate for this COE into the, hospital standards in Vietnam. I mean, the national hospital standards. So once the hospital, they get this certification, they will rank higher, I mean, in the standards of the hospital of Vietnam. So that is the motivation of why hospital, they want to have this kind of certification. So the key here is that we need to work with the Ministry of Health, the, the authority that they have the, the right and the authority for this. So that is the first one. We just measure the successful of the hospital who got certified. And I mean, every year we will verify again. It means that once you got verified, you have to maintain that to, keep going on to have that certification. It's not like one time for lifetime. It's not like that. So yeah, for the Little Sun Nutritional Clinics, we started this program like quite long ago. It's like more than 10 years ago. And so far we have more than 1,000 clinics. And for these models, we already handed over that to the National Institution of Nutrition, and to replicate that model nationwide. So here in Vietnam, at the moment, we have the national targeted programs. I mean, we have the 3 national targeted programs, which has a huge amount of, money from the government money. So this model will be, replicated by the government funding. And next we have the Mumbai apps. I'm so glad that I received a lot of questions about the Mumbai apps. I see.
Yeah, sorry, I thought that I had mistakenly said that they were for Sri Lanka. All of those questions on the Mumbai app are for you. So if you don't mind being a bit quick, I did have one question for Visakha as well. And so we have to move on really quickly.
Yeah. I think I will be quick about the Mumbai app. So the Mumbai app, you will see that it will be measured by, basic index as any, Mumbai, as any mobile apps, like in-app user, the community, and the time in the app. And actually the Mumbai apps, they were in the top 10 impact challenge in Southeast Asia last year. They are also the finalists of Google Startup Academy, and currently they are receiving some kind of a technical and financial support from Google. And actually the role of SUN CSN here, that we provide technical support and we connect Mumbai app, I mean, we connect that startup with the, appropriate source of funding and source of technical assistance. So this is what we are doing. So, and for the question about whether we apply this approach to Thai ethnicity, actually for ethnic minority, this approach were not so, that applicable, because they live far away. They do not own a kind of smartphone, and they're not so familiar with, technical things. So for the ethnic minority, I wish that I have more time on that, but we have different intervention for ethnic minorities. For example, we have the mobile health check, which we have like a car that we come into each household, and then we measure the nutritional state of them, and we provide counseling there, I mean, in their homes. So we have different intervention for ethnic minorities. And actually, currently, we are working very closely with the Parliament, I mean, with the National Assembly of Vietnam, to monitor the national target program for ethnic minority. Yeah, so that is my answer.
Right.
Yeah, and good news is that actually the Mumbai app is now in Vietnamese language, but they are now developing the English version so that can be replicated in other markets. For example, India or Jordan, we are actually in the process of working with other countries.
In the interest of time, I'm afraid those last two questions that I asked, we'll have to move on swiftly from there. I do think that the response to Anna's question about applicability in the context where smartphones simply aren't available, I think the quick answer is no, it wouldn't apply in that context because it is an app that is dependent on phone access. Essentially, that's how a phone app would work. I think, John, perhaps you could contact QN separately online so that you can, so that I think Behnish said the same. Could we have your email address to reach out to learn more about this? Because you did get quite a lot of questions about this app. So perhaps people could reach out to you individually afterwards because we are running out of time, unfortunately. Visika, I did have one question for you on the Sri Lanka context. You gave a very comprehensive presentation in a somewhat limited time, so thank you for that. But I mean, there is a specific history in Sri Lanka that I'm familiar with. There is a history of conflict, and I'm just wondering how that's impacted what you described. Has that had an impact on the access to the services that you described and the structure that you mentioned in the PowerPoint? Visika, are you still there?
Just a moment. Let me be very quick on this. Yeah, very good question. Thank you. And the beauty of the Sri Lankan system, and I'm not defending the government at all, is that our primary health care was never disturbed, even during the war. And the credit goes to the people who are in the conflict on all sides. So we need to send this far and wide and actually see whether there can be some improvements. But for a robust primary healthcare system, I must say that the north and east, south, west of the country now is kind of fully functional once again. Now, there was some sort of question, I think, on the Mombi app. It seems a very attractive app, but I think the topic of the day is about gender transformative and nutrition. So perhaps this app could be targeted to fathers, and maybe many countries could use it, targeted to fathers and also decision makers. And it can be an app for different levels. So perhaps we can, innovate around that. Let me stop there.
That sounds fantastic. Thank you so much, Visika. And thank you so much, Kian, as well. We know you're staying up a bit late beyond usual working hours in your parts of the world. So thank you. We are going to move on from our Q&A section straight on to Madagascar and Tanzania, starting with Tanzania. Thank you two so much and for putting up with the tight time issues as well. I'm going to have to ask the next few speakers to also stick to quite tight time issues as well. We're going to start with a presentation from Tanzania. We've got Jane Msagati is speaking on this. She will share a program which involves the development of stunting identification charts as a tool for community mobilization to equip wards and villages with information regarding stunting for children under 2 years of age. The program was developed with the World Food Programme and piloted in 3 districts. She's a project manager with about 15 years of experience in the fields of community health, nutrition, sexual and reproductive health, gender issues, child protection, and WASH programs. She has a vast experience in advocacy and capacity building in health, coordination of CSOs and managing sub-grantees. She has extensive knowledge and experience of government health systems with work focused on policy discussions around health and system strengthening from the national to subnational level to deliver results in health. She also has an interest in learning and using practical evidence to address the health-related challenge with end users in mind to influence social behavior change and achieve positive outcomes. She is joined also by Tumaini Mkindu. He is the executive director at PANITA, a SUN civil society alliance in Tanzania with more than 300 members across Tanzania. He's worked for reputable local and international organizations, as well as bilateral donors, holding various positions, including both leadership and technical responsibilities. He represents PANITA in various multi-stakeholder nutrition and health forums globally. He's also served as a vice chair for the SUN Movement Executive Committee, and he has extensive knowledge and experience in nutrition governance. But today we'll have Jane speaking primarily on the Tanzania program, the PANITA SUN Civil Society Alliance in Tanzania. And I'll let her go ahead and begin. And I'm again going to be a bit brutal about when to finish. Sorry, I appear to have made a mistake, and in fact, Tumaini will be presenting today rather than Jane. But go ahead, Tumaini.
Good afternoon.
Or Jane, whoever is choosing to present. Please go ahead.
This is Jane.
Okay, great.
Greetings from Tanzania. Greetings from the Partnership for Nutrition in Tanzania, which is a SUN Civil Society Alliance in Tanzania. Yep. So I'll take you through the growth monitoring chart that was created by Panita in partnership with WFP 2 years ago, but just for the interest of understanding, when we talk of growth monitoring, we refer to the regular measurements that is recorded, interpreted on child growth change in order to cancel, act, and follow up of the result. And it is envisioned that if growth is being monitored properly, then we are able to allow the early identification of children at high risk of malnutrition, but we are also able to assist in focusing attention and resource to children at risk. Also to motivate families and caregivers to change and improve practices, help the target tailor cancel messages. So that is in a nutshell what growth monitoring entails. Next slide, please. Okay, so just as I've mentioned earlier, WFP and Panita, together with government, we introduced the community growth monitoring chart, aiming at enabling identification of children under 2 years with stunting at community level. And it's a more user-friendly tool as opposed to the ones that are being used now, like growth chart and the like. And the results of this monitoring are submitted to the village authority, and the feedback is being done through the village meeting and the notice board that is found in the village authority office. But also the chart acts as a catalyst to spark nutrition dialogue in the community, as opposed to the current one that is mainly situated at the health facility. So this is mainly targeted to stimulate nutritional dialogue at community level. Next slide, please. Next slide. Previous slide, please. Sorry. Yeah. So, previous slide on the rationale. Yes. Sorry to take you back, but it is necessary for all of us to understand what was the rationale of having a growth monitoring chart. And therefore, the growth monitoring chart is aiming at addressing the challenges that we observe in the community, which include absence or shortage of growth monitoring tool at community level that identify nutrition status of children and that enables to take appropriate action. The other rationale of this is that parents and caregivers were struggling to identify malnutrition of their own children due to lack of specific references. And the other rationale was that low understanding among parents and caregivers on linkage between child nutrition, cognitive development, and child growth. And therefore, by having this at community, it gives an avenue for parents to understand the situation of a child and have more explanation from the community health workers as well as facility workers who always work on this in order for them to understand further on what step to be taken to improve the nutrition status of our children. But also, we introduce this so as we can stimulate more men involvement when it comes to care and support of children especially in addressing children nutrition issues. And therefore, this is a very important tool because it is a community-based, and we believe that more men will participate in following up the growth of their children. Next slide, please. So the coverage, just to earmark this, it was a pilot project, and it was done in only 2 regions of Tanzania, namely Dodoma and Singida. But also in those 2 regions, it was not done in the entire regions. It was done in 3 districts that were implementing the WFP Boresha Lishe project, and the districts were Ikungi, DC, Singida, DC, which are in Singida region, and Chamwino, DC, which is in Dodoma region. And the charts were introduced into 50 wards and 124 villages. And on the participation, a total of 475 ward and village leaders, as well as community health workers, were trained on how to use these community growth monitoring charts. Next slide, please. Yeah, but also we had a component of stakeholders, and apart from WFP and PANITA, but also government ministries and agencies participated. And the aim of doing this was increase ownership from the government and other agencies, but also to increase buy-in and for sustainability. And some of the stakeholders that we involved includes ministries, and on the ministries we speak of Ministry of Health, we speak of Ministry of the President's Office, Regional Authority, and local government. But on the agencies we speak of Tanzania Food and Nutrition Center, but also weight and measure agencies were involved as verification point to have correct, accurate information when it comes to measuring the children's growth. But also, since we're working with regions, districts, and villages, the village authorities were also involved as a mechanism to increase buy-in, ownership, but also to sustain whatever is being done in their communities. Next slide, please. So as you can see on your right-hand side of your screens, that is how the growth monitoring chart looks like. As you can see, the y-axis has 8, while the x-axis has the month. So when you see the 8 was in centimeters, and the month, as it is written in Swahili, miezi is month on the x-axis. This is how the growth monitoring chart looks like. And the mechanism on how it's done, you'll see in the next pictures that will follow on this slide. But also, just to explain a bit, the project developed the monitoring chart, which were printed on a plastic material and plot the chart's age in months from 6 months to 24 months along one axis and height along other axis. And it was for both boys and girls. Further to that, it included basic information on child health and nutrition and development milestones for children under 2. Next, please. As you can see on your right-hand side, that is how measurement is being done. The chart is being laid on the floor, and then a child is being laid. And as you can see from the picture, the child is almost stunted. As you can see, he is on the red part of the chart, which represents stunting. So in order to have this done, you need to have like 2 people. The first one who will be taking the measurement, but you need to have the mother next to the child to increase more comfortability. But you need to have someone who will control the legs to have correct measurement. So that is how this was done. And this was done after thorough training that was conducted to different actors, as I mentioned earlier. And many, as Elias said, that the village authorities were very much involved, but also the community health workers, the parents in those particular wards and villages, but also representatives from ministries, region, and councils were part and parcel of this exercise. Next slide, please.
I'm sorry, I am going to have to speed you towards the end, unfortunately, because we are running out of time somewhat. Sorry about that.
I understand you, and I'll consider that. So why do we have to use the chart as opposed to length board or other tools that we use to measure stunting? So the tool is inexpensive as compared to other tools. It is durable, but it's easier to use and easier to carry because it's a plastic material. It's a plastic paper-based material which can be carried anywhere. But the other value added is that it helps parents, caregivers, and community leaders to understand the situation of their children in their communities. And the other one is that it stimulates accountability by allowing leaders and health providers to know the situation of nutrition within their localities for them to plan well and advise well as far as nutrition is concerned. Next slide, please. With all that, we had some challenges and mitigation measures. The first challenge was to manage expectation from stakeholders, viewing that the chart would be an alternative to the length board because of cost implication. But our understanding was that will not replace the length board, but rather this will be based at community level, and the length board will be used at the facility level. And the community adaptability, because it requires the child to lie down, which is something which is not very known and not very practical to many societies as far as Tanzania is concerned. And to address this, awareness sessions were done to the communities through the local leaders. But the other challenge that we had was how well we'll be able to increase ownership among the local leaders on the need of having this. And therefore, as a mitigation measures, we work with local leaders for them to see what is happening, but also we think that we need to increase training, especially on the gender transformation, for them to own the exercise. Next slide, please. So how was gender transformation integrated into this activity? The first thing was it promoted men involvement in preventive care for children on nutrition issues, but also this chart addressed both male and female children, and therefore also it promotes women leadership roles and nutrition interventions at village health and nutrition day by attending growth monitoring clinics. The other thing was to sensitize community leaders to ensure that healthcare services are accessible to women and that they address the specific needs of women. Next slide, please. So having done this as a pilot, as I mentioned earlier, what is the way forward? FANITA is envisioning to scale up this initiative to other regions in Tanzania, and this is based on availability of funds, but also we are planning to involve more actors, both private and other ministries, so that we can increase ownership, understanding, but also to have more studies to validate this chart. So we welcome researchers and other people who are interested to work with us in this area. And the other way forward that we think is very important is to intensify the training on gender transformative approach to complement the initiative in order to increase ownership and sustainability. Yeah, so thank you very much. That's all from Tanzania. And I welcome you for questions, clarification, and even appreciation. Please welcome.
Of course, thank you so much. Thank you. We will see if we have time for a Q&A. We are actually running quite short of time, and I wanted to give the next speaker enough time to speak as he wants for the presentation he has on Madagascar. His name is Willie Jean Beninandiana. and he's currently the Executive Secretary of the HINA Civil Society Platform of the SUN Movement in Madagascar. HINA is a organization that stands for Harmonization of Initiatives in Nutrition and Food Security. It brings together 548 member associations and NGOs and spread over the 23 regions of Madagascar. He's a geographer by training and a social entrepreneur too, and he's been engaged for about 18 years in all sorts of positions of responsibility, going from technician in charge of projects to national coordination of programs in humanitarian development organizations too. He's also worked extensively in collaboration with civil society organizations, with state institutions, technical and financial partners, and parliamentarians on various themes. So let's look forward next to your presentation, Willie, on Madagascar. I'll let you go, and I will try and see if you can close it within 10 minutes. That way we can have a few extra minutes for Q&A, but I understand that you might have a bit more material. Thank you. Would you like to go ahead, Willie? Hi, I'm sorry if I'm interrupting, but I can't actually see the Madagascar presentation on screen. And I don't know if I'm listening to possibly the wrong interpretation, but oh, I see. Okay, because I don't see a presentation or the speaker. I would just thought perhaps because I'm in English, I'm having trouble. And he'll be presenting in French, so.
Yes.
Nazgul, what might be going on?
Willie would like to put the presentation himself to present it.
Anything? Nazgul, are you there?
Yeah. Can you hear me?
Yes, we can hear you.
Okay, I see.
But
So it's Willie speaking?
Yeah, you might need to click if you were in the English interpretation channel. If you're in the English normal channel, you might need to click on the English interpretation channel, and that should take you to the discussion. Willie.
We can hear the presentation from Madagascar, so we can't interpret anything. We're also waiting for them.
Okay, we might be having sound issues.
Great, I think we can, well, we almost saw, we can see Willie, I think. I can see him.
Hello, bonjour tout le monde. Salutations de
Greetings
Madagascar.
to you all. Greetings from Madagascar.
Great.
Kindly ask people to mute if those who don't have the floor should mute, please. I'm also requesting to be given the right to share my screen.
Sorry, yes, go ahead, Willie. The floor is yours now. Apologies for the delay.
Please, those who don't have the floor should mute.
Comme je disais, vraiment
So,
désolé.
as I was saying, I'm so sorry for this internet disruption. for Madagascar. I will present on the Women Leaders Project, the project that was implemented with the collaboration of the Shina platform, the nutrition platform, and the platform for water, hygiene, and sanitation, a project funded by AFD in 2022. Now, talking of the context or the background, the project was implemented in the southern regions of Madagascar and four municipalities, the Great South, which is a region that is attached to a discriminatory patriarchal regimes, and the right of women is limited, and frequently we record forced marriage and banishment from the clan in case of problems with family, especially against women in the region. And there's also discrimination against women as far as decision-making positions are concerned. So the project was implemented in these four municipalities, 4 areas, with the mobilization of women and young people in order to bring improvements in the local practices, and especially with regard to development or women-led development through water, sanitation, and nutrition. The project has been developed by giving value to national policies that were the project was aligned with national policies and regional development policies. We have also taken into account the lessons learned, the good practices from our previous funding, which was a funding from the SUN movement, WFP and UNICEF. We have also capitalized on all the information that were produced from the Shina members in every region, because the Shina platform is a civil society platform that intervenes in nutrition sector, and they are present in the 23 regions in Madagascar. So we have capitalized on all the information related to gender issues, and we have also carried out investigations in the southern regions of Madagascar in order to assess the gender aspect related to women and youth development. We have developed terms of reference for women leaders based on issues related to sensitization for water, sanitation and hygiene, and nutrition, sensitization for local leaders at the community level, and give them an opportunity to share and lead on different actions related to water, sanitation and hygiene and nutrition in the different areas targeted. Women also were brought in order to collaborate with local stakeholders and contribute with the support of community leaders and representatives of the government at the decentralized level. So there's also an experience sharing and sharing of good practices on water, hygiene, sanitation, and nutrition for local development, and carry out advocacy towards decision makers on improving the wash and nutrition situation in the different areas. In a general manner, or generally, the strategy reminded or took advantage of the agreement signed between the HINA platform and the governorate of the regions. We have also told the leaders that we need their support in order to facilitate our action on the WASH situation in the different regions. We've also implemented activities and organized workshops on information targeting women to raise the awareness on the importance of WASH, and also have carried out an assessment of hygiene, nutrition, and water sanitation in the region. We have trained them on advocacy techniques, human rights, the processes of local products, and how to store all these products. With all these strategies, and we have come up with a sustainability program, a strategy with the community. So from the beginning of the project, they were involved all over the process, and even including the sustainability strategy development. Now, impacts in talking of the impacts, we have observed improvement of discussion among the community leaders and groups of women and young people who were committed to bring change at the community level. Women have been really hailed for their participation on the issues related to water, hygiene, sanitation, and nutrition, and their advocacy capacities towards local community leaders that has helped to come up with a sustainability strategy for the project. So with all these achievements, the project has helped us to value the action carried out by women at the intervention areas. And with the activities for capacity building on food processing, it helps us to create new food products on the local market, including cactus jam, handmade soap, and cassava flour. But the most importantly, women and the youth know their rights and share all this at their community level. The project has also contributed in improving gender, because we have focused, or we have valued local cultures and organizations, community structures, and we have also requested for the needs of women, which were later on transformed into projects. We have also involved women and local community leaders in the implementation of the project. Moreover, we have mobilized government representatives, because the intervention was contributing to local development. So the government had to support the project in order to value the actions carried out by young people and women with regard to nutrition, water, sanitation, and hygiene. One of the most important points is the development of trust among the community through SHINA members who are working at the community level since 2013. So the interaction between SHINA members and the community has helped to achieve the objectives of the project, to support the initiatives led by women and gender initiatives in terms of water, sanitation, hygiene, and nutrition. Now, for the tips or advice we have to present here is that you need to listen to the needs of women at the community level, identify those needs, and support those needs through developing projects, and also come up with a discussion space to strengthen advocacy with leaders in order to improve the situation in which women and the youth find themselves, because the youth and the women are not very often listened to in the community. Now, to close, I wish to present also a video that will help us to see how this project has had an impact. So I'll share a video that will present the achievements by this project. And we don't have the sound, it's no sound. There's no sound, please. We don't have the sound. There's no sound, please.
Willie, if you can share the link with me, I can present it with sound.
He's gone from, oh yeah. Hi, Willie. Nazgul just asked if you could share the link with her, then she can.
I think I have it here, one moment.
Okay, great.
Après 12 mois d'activité. Après 12 mois d'activité, le projet leader pour le développement est mis en œuvre par la plateforme des organisations de la société civile pour la nutrition clean et la plateforme des organisations de la société civile pour l'eau, hygiène et assainissement, OSCEAH, dans 3 régions du sud de Madagascar, et soutenu par le programme PISPA, le Madagascar commence à donner des résultats et apporte un changement positif pour la commune.
Cette collaboration a permis de renforcer
This collaboration has helped us to strengthen the collaboration
de les stimuler à
and
renforcer les actions de développement au niveau des régions.
focus
C'est un
on
grand
development action.
succès que la plateforme IN et la plateforme OCH
The platform IN and OCH
Un succès vite confirmé par les témoignages
success
qu'ils ont
was
accordés sur le terrain.
confirmed by
Les
the
femmes
testimonies
marginalisées dans le
of what
passé
they
deviennent des
have
leaders
voiced on the
aujourd'hui,
ground.
des autorités
Women
qui apprécient les impacts
marginalized in
du
the
projet
past,
et souhaitent son
will become
extension
leaders.
Stéphane, à Anjouy et à Noussi. Commune d'Ambourpouts,
In
l'une
the commune d'Ambourpouts,
des 2 communes d'Ampani,
one
qui
of the
concentre
2
80% des
areas
projets eau
which
et assainissement de
concentrate
l'ONG Tahrat,
80% of
confrontées à la
the
dure-réalité
project
comme un taux d'utilisation de toilettes qui dépasse rarement le 1%, les
and
femmes
the
ont
use
répondu à
of
l'appel de l'ONG et se
sanitation.
sont organisées
So
pour
the women
devenir des
have
leaders solutions et
also
défendant leur
responded to
droit
this
d'accéder
project
à
and
l'eau
organized
potable
themselves to
et à
become leaders in
l'assainissement.
the field of
Les
access
impacts
to
sont
drinking water
visibles.
and sanitation impacts. And this is visible.
Il y a du vrai changement parce
There
qu'elles
is a
prennent
change
vraiment leurs responsabilités, ces
because
femmes leaders d'Ambourpouts.
they
Elles n'ont
are
plus
really
peur
taking their
d'aller au niveau
responsibility,
de
these women
l'hôpital
leaders
et
of Ambutsu.
discuter
They are
directement
no
s'ils
longer
ont besoin
afraid
de quelque chose.
to go to the local
Les
office
autorités
and discuss
traditionnelles
directly.
et
So
étatiques
the
sont
local
impliquées dans la démarche
authorities
et la
are
tiennent.
involved in
Le
this
maire de la commune d'Ambourpouts, qui a soif
project.
de développement
The
pour cette
mayor
très
of
large
the
circonscription, applaudit tout ce que
municipality,
les bénéficiaires du
who is
projet
thirsty
Femmes
of
leaders pour le
development,
développement ont
applauds
accompli
all
pour
the
améliorer l'accès à
beneficiaries
l'eau
of the women
potable
leaders
et à
of
l'assainissement
development
et rêve
project
encore plus.
have achieved and improved access to drinking water and sanitation and drinks.
Nos femmes manquent d'équipement. Pourtant,
Women
elles sont
lack
solidaires. Elles font bloc
equipment.
face à la
They
difficulté.
are standing
Ceci
against
dit,
this
ce manque
difficulty.
d'équipement est un
A
handicap.
lack of equipment is a handicap.
Le changement qui est en train de se mettre en place à
Change
Timanamad
which is being
a montré
observed
aussi l'efficacité du projet Femmes Leaders pour le
demonstrates
développement
the efficiency
grâce à la
of
collaboration
the
avec
women's
l'association des femmes
program,
sous route.
thanks to
Le
the
problème de
collaboration of
déprécation à la
women
rive
in
fait
Ambus.
partie du passé. Les femmes se sont aussi donné la main pour
Women
nettoyer un
have
vieux
also
bassin
joined
programme
hands
abandonné et
in
envisager de le réhabiliter. Il y aura un changement pour Timanana puisqu'il va être réhabilité et deviendra une source de revenus pour l'État. Une fois réhabilité, le bassin servira de stockage pour l'association Fiavout, qui distribuera de l'eau. Grâce au soutien du projet, les membres de Fiavout ont commencé à produire et à vendre des tracteurs de fruits de cartouches rouges pour financer cette réhabilitation et aussi pour améliorer la transformation et promotion des aliments locaux à forte valeur nutritionnelle. De plus, convaincus par le changement en cours, les hommes ont promis d'aider les femmes au moment de la réhabilitation du pluvium. Les graines du développement germent là où le projet Femmes Leaders pour le développement s'établit. Le village d'Amboukar qui ambitionne de devenir un site touristique a vu cet objectif à long terme s'approcher. Depuis que les associations des femmes sont entrées dans le jeu, le village est devenu plus propre. Le point focal de Nazaï, qui était témoin de changements, milite maintenant pour une reproduction du modèle utilisé à Tananda.
Il est préférable de donner le pouvoir de décision aux femmes en milieu rural. Les hommes vont naturellement suivre. Nous avons œuvré pour le développement depuis longtemps, contrairement aux femmes. Pourtant, c'est prouvé que les femmes sont plus efficaces pour emmener le développement comparé aux hommes parce qu'elles travaillent avec conviction.
Les femmes de Tanadav ne s'assoient pas sur leurs succès et commencent à se projeter dans l'avenir pour tenter à toutes les bonnes volontés.
Chine nous a déjà beaucoup aidés et formés. Nous sommes suffisamment formés, mais il nous manque les outils.
Amplifions les souhaits des bénéficiaires de projets Femmes Leaders pour le développement, les deux plateformes de la société civile et OSCEH souhaitent tout naturellement sa poursuite et vise encore mieux.
Ainsi, pour la suite, il est important de mettre un peu plus de moyens pour avoir la plus d'impact.
Le chemin est encore long, les besoins sont énormes, mais les défis de succès sont là pour servir de tremplin de développement pour ces trois régions du sud de Madagascar.
Hello. Okay, so thank you very much, Willie, for that presentation and the video as well. We will share the link of the video. I believe what Nazgul will do at the end of this is to collate a bunch of the presentations and any relevant links and contact info too, if there's a possibility that you might want to ask questions to individual people. And so you will have a recording of this too. For anybody who's attended, you are going to be included on the email list to send these materials to. So I hope that will be helpful. I haven't seen any questions being added to the meeting chat, and I don't have any immediate questions of my own. Was there anything, we do have a few minutes left. Was there anything that either Willie or Jane would like to ask of each other in terms of programs? Okay, it doesn't sound like it. It sounds like everybody is okay to wrap up, I believe. So thank you so much to our speakers. Thank you so much to Jane and Willie and Kian and Visaka, who aren't here anymore. Well, Kian had to leave, but I think Visaka might be here. But thank you so much for the time that you took to give us these presentations and a lot of food for thought, thankfully. And I hope we continue to have these discussions as we go on. And this hopefully was an opportunity to get a sense of what is going on with these programs in terms of sort of exchanging information across different regions as well, which is always a useful thing to do. I'd be very grateful to keep in touch. So I think this conversation hopefully can be continued in the future as well. And thank you so much to Nazgul for organizing from beginning to end, and the interpreters. We are very grateful for the interpreters because that is not an easy job to do at the pace, particularly I know that I speak very quickly. So I hope I didn't give the interpreters too much trouble, but thank you so much. And hopefully the next time we have something similar to this, you will be able to join us next as well. Thank you. Bye-bye.
Thank you. Thank you so much, Dr. Tahrat, for moderating and for all the wonderful speakers, their presentations. See you all soon.